Good morning, everyone. Today is Wednesday, May 19th. Yet another beautiful day in Sonoma County. One of these days, we're going to do this. I'm going to say it's a beautiful day. It's pouring rain, but we're hoping for that day to come at some point. But it is gorgeous outside today. Gary's with me, of course, and we're going to move into some topics. But before that, just some general announcements. You should know that our large mass vaccination site at the Luther Burbank Center will actually be closing. Demand is down. So as of this Friday, the 24th, I believe, or this Friday, we'll be closing that site, and vaccinations will then be given at room 310 at Airway. Much smaller, it has a capacity of about 150 or so. Do recall now that we are vaccinating 12 to 15-year-olds with the Pfizer vaccine. I'm told that quite a few people have done that already. But the demand for all vaccines seems to be weaning off a little bit. I do want to take a moment to acknowledge the success of our mass vaccination site at Luther Burbank. It got up real quickly, and it was vaccinating thousands and thousands of people. And just to name a few people, it really was a brainchild of Aaron Neal and Jonathan Richards. Kathy Woodcock kind of managed the show there. Tina Harms, Jessica Harkins, Chip Fisher, Sinan Rosenberg, all critical elements. And Mark Minnie from the hospital, he managed the assets, the vaccines to a great extent. And, apologies to the other 50 plus people who each and every person is an integral part to pull that off. Quite a commitment to our community. And as you'll hear later, very successful efforts. So, Gary, let's move into kind of what I like to talk about every time we meet, and that is start off with the epidemiology. Where are we at in the world in Sonoma County?
Yeah, so in the United States, I think we're doing great. We're doing better. But in Sonoma County and in California, I think we're doing kind of leading the way in improving low rates, opening up economies, and doing it safely. I'll show the first slide. This is India. India's been in the news a lot. Last time we had a video, I misspoke. India has 1.4 billion people, not 2 billion people, but in a 1.4 billion dense community which has different infrastructure, India is still struggling with 300 to 400,000 cases a day. Now on the map you'll see that they've got this huge second wave. However, we usually count this in 1,000 or 10,000 increments. On this map for India, it's counted in 100,000 increments. So they're having thousands of people die a day. I think I saw an article in the New York Times, 25% of healthcare providers in certain communities have become infected. So India is struggling. When you get to that certain critical point, you see the infrastructure medically kind of collapse a little bit, where they run out of oxygen, they run out of other medication, they run out of beds. We face that in LA, almost running out of ICU beds. And so that's a critical point where things start to collapse, and I think India is struggling not to let their infrastructure collapse under this. So India is going to be a hotspot for us to watch for variants, because the more mixing, the more transmission, the more mutation, and the more variants you'll see out of that so far. So the next slide is actually what's happening in the Sutter footprint, and this looks very similar to Sonoma County. Our rates are really low. We still have a few patients in the hospital. I'm still rounding on COVID patients every day. So our numbers aren't zero. They're lower. Our ICU has a couple people in it, not 7, not 8, but it's still out there, and we still need to push for more vaccination.
Yeah, and I understand that there's an article today in the paper that Sonoma County failed to drop down to the yellow tier recently. I don't recall what the limitation is, but we're stuck in red still, or orange rather.
Yeah, we're stuck in the orange tier because we're still more than 2 cases per 100,000 population.
Okay. And
that's really holding us back. And so we're still seeing a little bit of transmission. Now, maybe that's due to some of the variants. We've seen almost all of the variants in California, South Africa, India, Brazil, the UK. And the variants are a little bit more transmissible. That's why they're variants of concern, because their transmissibility is higher. But I think people are starting to get tired, and people are starting to kind of pull back a little bit. And then there's been this conversation with the CDC on masking, not masking, and there's still this vaccination hesitancy in certain pockets.
And then this tier system will be thrown out the window as of June 15th. I think the governor has declared that basically we're back to normal, whatever that will mean when those rules come out.
Yeah, so Governor Newsom's going to remove the whole tier system by June 15th. They'll be very curious to see what happens at that. If I was an epidemiologist, and I'll talk to my colleagues at Sonoma County, be curious to know what they're going to think about our case rates, because we're still going to be counting cases.
Yeah.
It's just we won't have the public health mandates that impact our businesses and our economy.
Okay. Let's get into vaccine rates. How are we doing locally?
So Sonoma County is doing well. I'm going to show another slide here. This slide kind of shows where we are as of this morning. In Sonoma County, we've given over 500,000 vaccines for a population of 485,000. 72% of people over the age of 65 have received a vaccine in this county. And we always talked about 70 to 80% being herd immunity. Mm-hmm. So we're at 72% have had one vaccine, 57% have had both vaccines, 28% are not vaccinated, and we're really relying on Brian Pertowski to fix that problem. Mm-hmm. Brian is out there grassroots really working with a consortium of people, and we're grateful for his work. So we're trying to get to that last 28%. I also put on the slide here a breakdown of ages, just to shout out that over 65, more than 82% of people are vaccinated, and layer on top of that natural immunity from natural infection, and I think we're really approaching herd immunity here.
So I have a question about that. We've talked about herd immunity for a year, and it's always been this mystical term off in the future, but we're almost there now. So can you tell me what it means? I need to fully understand. What does that mean, herd immunity?
Right, so it depends on what your target for herd immunity is. Are you trying to prevent deaths? Are you trying to prevent hospitalization? Or are you just trying to prevent infections, symptomatic versus asymptomatic? So there's different ways to study herd immunity. And I'll show the next slide because I want to give an illustration. Herd immunity is really based on what we call the R0 number, or the basic reproductive number. That's a capital R and a little zero. The R0 number, or the basic reproductive number, tells you how contagious something is. The more contagious something is, the more you need to protect the population in order to break an epidemic. And so in this example here, you see to the far left, a person in red, that's an infected person. And they go into a population of people with blue, and when they mix with that very susceptible population, 3 people get infected from that one person. So we call that an R0 number of 3. With a second wave of transmission, you'll see that 3 people become 9 people infected, and it becomes exponential. So that's an R0 number of 3. I'll also show that on the right, and I'm gonna sort of tell you where I got this. This is from Wikipedia, but it's good. The references are good. These are different R0 numbers for different things. Measles, R0 number 12 to 18. So that's why with measles, you need a very good vaccine and numbers above 90% vaccination rate to break an epidemic. And that's what happened in Samoa a couple years ago before the COVID pandemic. There was an outbreak in Samoa. Vaccination rates were low. Incredibly contagious virus out there. And just for you, for Trivial Pursuit, what is the most infectious bacterial agent? Look down this list, is pertussis. Pertussis comes in at number 5. So the R0 number doesn't mean virulence. It just means how contagious it is. So yes, pertussis has an infant mortality associated with it, but it's not very dangerous for older adults. However, it is contagious. So the R0 number talks about contagiousness. It doesn't talk about virulence, just to kind of point that out. And I put that for your reference here. Now, let's go to the next slide. This is going to be important. So if you take that R0 number of 3, and the R0 number is not a constant, it changes. So if you do hand washing, if you do masking, if you socially distance, you can delay and a little bit affect the R0 number with public health measures. But the biggest thing for the R0 number is vaccination. So you have one person here with an R0 number of 3, 3 people get infected. But now on this slide, what if the next step, you bring in a vaccine? Now, from the 3 people infected originally, only 1 more person becomes infected. So now you change the R0 number, and when you change the R0 number less than 1, now you break the epidemic. So the R0 number of 1 to 1 means 1 person gets infected, they pass it on to 1 person, they pass it on to 1 person, and the epidemic can continue, but it's not growing. But if you can lower the R0 number to less than 1, where 3 people are infected, but only 1 more person gets infected from any of those 3 people, now you've broken the epidemic. That's what herd immunity is. When can you drop the R0 number less than 1? So the last slide, I actually showed this in Grand Rounds. This is a slide that shows vaccine efficacy. vaccine efficacy is based on contagiousness. So if you have a very contagious disease, you need a vaccine with high efficacy. If the disease is not so contagious, you just need a vaccine that's pretty good. And so I put in red here, a red box. That's kind of this calculation number for vaccine efficacy. And just to know there's science behind it. It's a mathematical number based on science, based on the contagiousness. And so, for example, our influenza virus is like 20 to 60% efficacious. It's not that great. And then we come out with this mRNA.
Vaccine, you mean?
The vaccine.
Yeah.
And then we come out with this mRNA vaccine for COVID-19, and it's 96, 95, 94% effective. It's almost like the measles vaccine. It's really that good. And so we are very lucky, at least in the US, to have a vaccine that has high vaccine efficacy for a moderately contagious disease. So the R0 number for COVID, if you look at the other slide I showed you, is about 2.5, 2.9. It's going to change a little bit with the variants, but it's not 18.
Yeah.
So we have a moderately infected virus, a little bit more than the flu, but an incredible vaccine. And that's how we're going to drop the R0 number. So I think our vaccination rates in Sonoma County were about 72%. I think we're kind of in that sweet spot. We're approaching that sweet spot to really break the epidemic. And so that's why we're seeing so many few cases, but you never get down to zero unless you do everything right.
So that really helps me understand, because herd immunity then is not one specific point. It could be different levels depending on what your goal is.
Right.
And that was a good job to tell us all the variables that are
Right.
involved in that. So it is appropriate to say we're approaching herd immunity, because I'm not sure you ever get there,
Right.
but we're approaching the point where our R0 numbers certainly will be dropping and hopefully becoming negligible.
Right, and then as long as you have vaccine hesitancy, you still have a vulnerable population that could get infected.
Yeah.
So as long as you have a vulnerable population to be infected, and people are not doing public health measures, you're going to see a trickle of cases. But it doesn't mean the epidemic is here.
Okay, so let's say we've reached herd immunity, and that's what they're going to say in the newspaper. So what does that practically mean? I mean, how could one translate that into public policy, or say masking, for instance?
So it's a good question, because we've been talking about that on the SHEMS group and on the IDCAT group, because we're talking about revising. And with Elaine McCann's help, we've been looking at policies again to say, okay, do we need to change our policies? So we've stopped temperature screening at the door.
Right.
One, because rates are coming down, and two, because that didn't help us very much. Masking is a big one. It's a big CDC change recently. Outdoors, masking was never so important, because this virus is not so contagious outdoors unless you're in a crowded setting, like a football game, a baseball game, a concert. And so if you're crowding outdoors, especially shouting, there's a risk of transmission. But if you're jogging in Annandale Park and you're passing people, the risk of transmission there is really negligible to zero.
Yeah.
Indoor masking is a different thing. So indoor masking, if you're vaccinated, is where the CDC says that you can actually forego that unless you're in certain settings. So if you are in any ambulatory or hospital setting, you need to continue to wear a mask. If you're in an airport, on a bus, in a subway, you need to wear a mask.
Mm-hmm.
So in some indoor public settings. And then other indoor settings, I think it'll be interesting to know if we continue to wear a mask as a precaution or we stop wearing masks. So I think we're learning that right now, and the CDC is basing that on
How could that play out? Because you see other countries where wearing a mask is fairly routine.
Yeah, so I think that's going to be that's an interesting point, because it's kind of based on cultural norms, right? So we are a country where individualism is important.
Yeah.
And so that's become very controversial, whether people think that masking infringes on their individual rights. Other countries, let's say in Asia, mask has become the norm. Now, part of that's because of pollution.
Yeah.
So pollution is pretty bad in China, people wear masks, and it's become fashionable in China, and it's become fashionable in parts of Asia where masking is kind of normal. But there's also a difference in their culture, where people are a little bit more conscious of community effects, and they balance that with their individual effects. I think our country, we don't balance the community effects as much as we demand our individual freedoms. And so I'm curious if it's going to be a norm here.
Yeah.
Now, this year with influenza, we were masking, we were washing our hands, we were socially distancing. We didn't see an influenza season. In fact, following the CDC data, one pediatric death was recorded this year from the influenza.
Period.
In the entire season, in the entire US, one child died of influenza. That's unheard of.
Yeah.
We've never seen that before. We usually calculate on how many hundreds of children die of influenza. And so we know that masking, washing our hands, social distancing is going to be really important. I will continue to probably wear a mask inside of Costco. Or I will continue to wear a mask inside of Safeway. I'm going to encourage my mom to continue wearing a mask inside a church. I think it's just very, very helpful. And I'm going to keep hand gel in my car now.
Yeah.
So when I get in and out of the car, I'm going to wash my hands to make sure that I don't just get a common cold virus.
Yeah.
That, I think, would be very helpful moving forward for simple things like respiratory illnesses.
So the good news is the background transmission is coming down. We're reaching herd immunity. Obviously, everybody still has the need or desire to practice, conscientious actions for themselves.
Right.
But it's becoming less of a social mandate. So
Right. Yeah. So
we're moving
kind of,
along.
Yeah, we're pulling
Yeah.
back on what's mandated.
Yeah.
But it'll be curious to see what's left behind as healthy practices.
Yeah. So thank you. This is good stuff. I've always wanted to hear more about herd immunity. I'd like to think that we're moving along, put this thing behind us. Of course, it's kind of always going to be here. We'll have a new normal. But I think as we've seen rates come down, we've actually seen some inverse return to normal in our practices. I just want to give a shout out to every single provider. You guys are working very hard. The month of March, we had our highest volume since January of 2020, and the month of April followed closely behind. So inversely, our practices are getting closer back to our normal work as the virus goes down. So hopefully that's good news for all of us to get back to doing what we trained and love to do. So thanks for your time. I do want to remind everybody, tomorrow night, Thursday, is our next all-group meeting, so hope to see you there.